All right. Hi, everyone. Thank you for joining us today for the April 2026 ACES Quarterly. This session's topic is on Washington State's new Maternal Mortality Review Panel, or legislative report. And today we have guest speaker Debs Gardner, who is the Maternal Mortality Review Coordinator at the Washington State Department of Health. She manages the State Maternal Mortality Review Panel and co-authored the state's legislative report on maternal deaths. She is passionate about perinatal health equity and public health communication strategy. Welcome and thank you, Debs. I'll pass it off to you to share your screen.
Great, thank you so much for the introduction. And let me get my slides up here a second. Great, yeah, so thank you so much for having me to present about our fairly recently released Maternal Mortality Review Panel report. It just came out in December of 2025. Can I get kind of a show of react hands? How many folks are familiar with the MMRP in Washington, the Maternal Mortality Review Panel? Cool, I see some hands and some thumbs up. Okay, cool. Looks like about half and half. That's helpful to know. Great. Well, thank you so much. So I want to kind of set a background place of where we're coming from before I go into the information from the report. And I'm going to give a little bit of background about the MMRP and then talk about the findings from the report and recommendations. And then we'll have some time to talk about what are recommendations that resonate with you and with your work and with this group. What kind of implementation efforts are you aware of or participating in or want to be engaged in? Who might you want to collaborate with and things like that. I'm also going to put a link in the chat to the report so you can have a copy of it to reference. But this place I want to start from is that any maternal death is unacceptable, and that the work we're doing, we're hoping to prevent deaths, but also to address the inequities that drive maternal mortality and improve the well-being of adults and children in Washington. And that includes things like improving perinatal care and everything that relates to perinatal health and experience. So Washington State's Maternal Mortality Review Panel, or MMRP, we are actually one of many in the country. Basically, all states do some form of maternal mortality review, and the vast majority of us are at least partly funded through CDC, and we share data and communicate with one another. This is a map from CDC, and the dark blue states in this map are states doing, and actually also territories, doing maternal mortality review funded through CDC and then participating in this kind of data sharing process. The lighter blue states are not currently funded through CDC, but are participating in this. And then Texas stands out. They are actually still doing a form of maternal mortality review. They still have a maternal mortality review committee. They're not participating in the national work through CDC. But in Washington, our panel in its current form was established in 2016 by the legislature following the enactment of a Senate bill. And that's a reference to the RCW you see on the screen there that guides our work. The law was actually amended in 2019 to make the panel permanent and add some more details about the panel and its process. And this law basically directs the MMRP to conduct comprehensive reviews of every death of a Washington state resident that happens during pregnancy or up to 1 year after the end of pregnancy. The law does a couple other things as well. Like it gives DOH the ability to request the kind of medical and other records that we need to be able to prepare the panel for these reviews. In Washington, our MMRP is housed here at DOH. And we are actually the largest in the country. In the term that this report covers, we had about 80 members, and we actually have about 100 now. Not everybody comes to every meeting, but we have a real extraordinary breadth of expertise and backgrounds represented on the panel, including a priority focus on American Indian and Alaska Native communities due to some inequity-driven disparities that we see in our reports data repeatedly. And I'll get into that a little bit more in a few minutes. And then this panel, as I mentioned, they review a de-identified summary of every death of a Washington resident in pregnancy through 1 year postpartum, and deliver a report to the legislature every 3 years. I mentioned that breadth of expertise areas. This is only a very small sampling, and virtually every member brings multiple types of expertise. These include things ranging from lived experience to maternal fetal medicine, ACEs, doula care, indigenous lactation counseling, substance use disorder, home visiting, mental and behavioral health, perinatal quality improvement, and just so many other areas. We are, again, very lucky in Washington to have the folks that we have on the panel. And if you are on the MMRP and would like to mention that in the chat, I invite you to do so. So the process of reviewing these deaths, this is kind of the big picture process from getting information to creating a report. And in a couple minutes, I'll tell you more about the process of reviewing each death individually. But first, DOH identifies and confirms deaths and then requests medical and other records. As I mentioned, we have permission to do that because of that state law. And we have nurse abstractors who write a de-identified summary of the person's experiences, death, and care based on this information. But of course, they take out any information that could suggest who the person is, where they received care, where they lived, or anything else that might identify them. The panel meets to review the death and make recommendations for prevention. And then every 3 years in preparing for this report, the MMRP members and DOH staff work together to consolidate and narrow down all of those recommendations from the last couple of years and compile all of the data from those last few years and the priority recommendations into a report. I'm going to give a couple definitions here because these are actually a little bit nuanced, and I will be referring to them again in a couple other places in this presentation. So we use the term, and these terms come from CDC, pregnancy-associated deaths as this broad umbrella term to refer to any death from any cause that happens to take place during pregnancy or up to 1 year later, regardless of whether the death was related to pregnancy. Those are pregnancy-associated deaths. And of those pregnancy-associated deaths, some of them the panel determines are pregnancy-related. They were caused or worsened by pregnancy. And there's many of the examples of this are exactly what you might imagine. So a pregnancy complication or a chain of events initiated by pregnancy. But it's actually broader because it also includes things like an unrelated condition that was aggravated by some aspect of pregnancy, birth, postpartum. And then some of the pregnancy-associated deaths the panel finds are not pregnancy-related. The cause had no connection to pregnancy whatsoever. And then for some deaths, the panel determines that they actually don't have enough information to determine whether the death was related to pregnancy. So how the cases are reviewed, I want to emphasize that this is done very respectfully. The panel is encouraged to think of each person who died as though they were a loved one or other relative. And then looking through this de-identified case narrative summary that's been prepared for them, they discuss, was this death pregnancy related using those definitions we just talked about? And was it preventable? If it was preventable, was it preventable from a clinical perspective? But also, was it preventable from an equity and or social determinants of health perspective, which can include upstream factors? They ask questions like whether racism, discrimination, and bias played a role, and what factors contributed to pregnancy-related preventable deaths, the things that, you know, if this were different, this person might have lived. And then based on those factors that contributed to those deaths, they make recommendations. They brainstorm what are some types of interventions or systems changes that could help prevent a death like this, either at the time or even years before upstream. And again, those recommendations become the basis for the recommendations in the legislative reports that we put out. Okay, so I mentioned the legislative reports and I linked it before in the chat. There's also a QR code here on the screen if that's easier for you. This report was submitted to the legislature in December. This is the 4th MMRP report in Washington. The aims of this report are to prevent maternal deaths, raise awareness about those factors that contribute to the deaths, promote change, increase health equity, and improve perinatal care. The new data in this report are from 2021 and 2022 maternal deaths. And then there's also some cumulative findings from the whole span that we've been doing these reports, so 2014 through 2022. And for those who are very familiar with our reports, first of all, thank you for being very familiar with our reports. You might have noticed our last report actually came out a little less than 3 years ago. It was in February 2023. That report introduced 4 new years of data. And the reason for that was we got an extension for that previous report to add an extra year to have a little more time to do it so that they could get a glimpse into the COVID era. So that report went through 2020. This report kind of sets us back on our original schedule, which is why there are 2 new years of data instead of 3. The report has recommendations geared towards the legislature and other audiences. The report also has an addendum from the American Indian Health Commission with findings and recommendations from tribal and urban Indian leaders and communities, specifically addressing the types of inequities and disparities mentioned in the report. And the American Indian Health Commission does do presentations about that addendum and the work went into it. If that's something that you're interested in, please let me know and I'm happy to put you in touch to see if that would be a possibility. So again, for those of you who are very familiar with our reports, there's a couple things that are new with this report format. We tried to keep it a little shorter and more focused. We have a stronger focus on the legislative audience. The state law about the MMRP specifically says that the report is for the legislature, but that's not to say there aren't many other audiences very directly, that the report is very much directed to as well and included in it. But the legislative recommendations are centered first in this report, and they're in a separate section. We also wanted to incorporate storytelling this time around. We don't have stories about maternal deaths. Again, those are very confidential, but these are stories that we're calling Voices from Washington that people offered about their experiences in pregnancy, birth, or postpartum, experiences and challenges in the state. And these are really helpful, particularly for the legislative audience, in highlighting why many of these recommendations matter, the implications far beyond even what this report covers. We also have some stories, some success stories about implementing recommendations from the last report. Okay, so I'm going to give an overview of maternal mortality data that's shared in this report. And normally our epidemiologist presents this. She's actually at a conference right now with some of the other states. So if there are any really detailed questions about the data, I'm happy to put you in touch if there are things that I can't answer. Before we dive in, there are a few important considerations to keep in mind thinking about the data from this report. So first of all, maternal mortality is a relatively rare event, and that means we're often working with really small numbers, and that can make the kind of rates we're talking about unstable, especially when we're breaking down by, say, specific demographic groups. Also, Washington state maternal mortality data isn't generalizable beyond the state. It shouldn't be interpreted it should only be interpreted within the context of our state. But that said, even with these limitations, we can still use these data from the report to identify certain patterns and make meaningful recommendations and interventions in the state. So the US, as you probably know, has the highest maternal mortality rate among wealthy countries. And in the next couple of slides, I'm going to provide some national and state level rates. But I want to clarify, we don't show the national rates and the state level rates together. We don't compare Washington and the US because the national definition of pregnancy-related deaths differs from Washington's definition. It isn't as broad or inclusive. The key definition is that the national rate doesn't include injury deaths. And in the definition, it includes homicide deaths, suicide deaths, and accidental deaths, which includes overdose deaths. And you'll see that that actually leaves out a whole lot of maternal deaths that we count in the state. So you can't really say clearly how Washington's rate compares to the US rate overall because of that. Okay, so with that in mind, let's look at the national rates of pregnancy-related mortality. These data are from the National Pregnancy Mortality Surveillance System, which is also called PMSS. So you can see there's a noticeable increase in maternal mortality rates during 2020 through 2022 compared to the previous years in this chart. And national research has linked this rise experienced in 2020 and 2021 specifically, primarily to the COVID-19 pandemic. And the increase was driven not only by the direct impact of the virus, but also by things like COVID-19 exacerbating existing health conditions and disrupting access to healthcare overall. Although it's not shown on this slide, national maternal mortality rate, national maternal mortality data also highlight disparities by race, ethnicity, and age, and they do reflect many of the same types of disparities and inequities we'll be talking about today. So here we have the Washington state rates from 2014 through 2022. And as I mentioned earlier in the presentation, pregnancy-associated deaths is a broad category, the overarching category that includes any death during pregnancy or with 1 year after pregnancy. So that's the darkest line, the dark blue line you're seeing on the top. And the lighter dashed lines basically add up to that dark line. The pregnancy-related rate is, I believe, the lighter green line, and then the rate that is pregnancy associated but not related is the light blue dashed. Excuse me, I have that backwards. The pregnancy related rate is the light green dashed line, and the light blue dashed line is the pregnancy associated but not related rate. So Washington's pregnancy related maternal mortality rate peaked in 2021. It went up, and that highest rate was 33.4 deaths per 100,000 live births, followed by 27.6 in 2022. And those are the highest rates observed in Washington in this whole span of 2014 through 2022. And that increase in pregnancy-related maternal mortality, which is really the first that we've seen like that in these reports in Washington, is likely due to a couple of factors. So first, a rise in overdose deaths, particularly those involving fentanyl, which has become more prevalent and deadly. Second, deaths related to COVID-19, and that's primarily in 2021. And then finally, the Maternal Mortality Review Panel has continued to evolve their process for deciding on pregnancy relatedness and understanding pregnancy relatedness. And so that can impact the number of pregnancy related deaths that they identify. So let's take a closer look at the maternal deaths in Washington in the 2 years that this report focuses on, 2021 and 2022. So for those years, we identified 107 overall pregnancy-associated deaths. And then if you look at the second row of this chart, starting from the right, you can see 46 of the 107 pregnancy-associated deaths were determined not to be related to pregnancy. For 10 cases, the panel couldn't determine whether the death was related to pregnancy. So this leaves 51 deaths that the MMRP determined were pregnancy-related in these 2 years. Finally, the panel also assessed whether each pregnancy-related death was preventable. And of those 51 pregnancy-related deaths in those 2 years, they determined 42 were considered preventable. So let's talk more about that. So that works out to 82% of pregnancy-related deaths in these 2 years were preventable, meaning there was at least some chance that the death could have been averted if some factor, clinical, equity, and/or social determinants of health related, that contributed to the death had been different. And I want to acknowledge that 82% is very high. It's pretty similar to what we saw in the last report, which I believe was 80%, and also the numbers that other states tend to see. But I also look at that high number as reflecting the fact that we understand what it means for a death to be preventable. And this means we can take action. We know what to do. Because we can identify these as preventable, so we can identify the contributing factors and the recommendations that would correspond. So of course, unfortunately, inequities and disparities persist in pregnancy-related deaths in Washington. So in the next few slides, I'm going to provide some cumulative findings going back from 2014 through 2022 and discuss how, depending on age, race and ethnicity, geography, and also insurance status, the rate of maternal mortality differs in Washington. So let's start looking via age. So the graph on this slide and the demographic breakdowns provide frequency of pregnancy-related deaths in dark blue, which tells us about the actual burden or volume or number of pregnancy-related deaths. And then the rates per 100,000 are in light blue. That puts the frequency relative to the size of the population or subgroup. And so that allows us to compare between groups of different size. The rates include confidence intervals, and that's sort of the thin lines that you see sticking out. And that's really important because the confidence interval quantifies the uncertainty around these estimates, particularly when the numbers are low. Also, if a subgroup is marked with an asterisk, it means the rate has a relative standard error that's greater than 25% of the rate itself, which indicates that the estimate is statistically unstable and should be interpreted with caution. Okay, so for age, this is the breakdown of age. Pregnancy-related mortality occurred most frequently among individuals aged 30 to 34. This was followed by those ages 35 to 39. Although individuals who were age 40 and older had the fewest pregnancy-related deaths in terms of absolute overall numbers, they experienced the highest mortality rate. And that reflects the fact that while fewer people in this age group give birth and fewer die overall, their risk of dying from pregnancy-related causes is disproportionately high. So these findings highlight that the risk of pregnancy-related death increases with age, especially for those over 40. I'm just going to glance at the let's see. I will get into causes of death in a couple of slides, and I'm happy to do my best to answer that question about infection and sepsis. Thank you. Okay, so let's look at disparities by race and ethnicity. Non-Hispanic American Indian and Alaska Native people experienced higher maternal mortality rates than any other racial or ethnic group. Although the absolute number of pregnancy-related deaths is low, their risk of dying from pregnancy-related causes was 7.3 times higher than that of non-Hispanic white people, which reflects this alarming inequity-driven disparity. And that, again, is one of the reasons we have an addendum from the American Indian Health Commission at the end of this report. Also, non-Hispanic Native Hawaiian, Pacific Islanders, non-Hispanic Black, non-Hispanic multiracial individuals experienced high rates of pregnancy-related maternal mortality. When we look at pregnancy-related mortality by an individual's primary insurance, people with Medicaid experienced both the highest number of pregnancy-related deaths and the highest maternal mortality rate at 36 deaths per 100,000 live births. And these figures highlight the critical importance of ensuring access to quality care and support throughout the perinatal period, all the way up to a year postpartum or beyond, for individuals covered by Medicare. So lastly, we're looking at pregnancy-related maternal mortality by rural or urban residents. So although 122 pregnancy-related deaths occurred among people living in urban areas, a higher number, the overall maternal mortality rate was highest among people in rural areas at 26 per 100,000 live births. And this underscores the importance of improving access and also maintaining access to quality maternal health services in rural communities. So now that we've looked at how pregnancy-related mortality varies across different demographic groups, I want to shift our focus to better understand why these deaths occurred. And then next we'll explore the causes, timing, and contributing factors behind the pregnancy-related deaths. And this can help us see the bigger picture of the challenges faced and where interventions might make the greatest impact, which kind of leads us into talking about the recommendations for those interventions. So looking at pregnancy-related deaths from 2021 and 2022, the top 5 leading causes of pregnancy-related deaths were accidental overdose, COVID-19, suicide, cardiovascular conditions, including peripartum cardiomyopathy, and thrombotic embolism. These causes highlight a mix of clinical, mental health, and social challenges that contribute to pregnancy-related mortality, underscoring the need for comprehensive approaches to prevention and care. And this is where I want to kind of address the best I can, I think, the question in the chat. Because we're only looking at 2 years of data, sometimes these causes, the leading causes, will fluctuate. And again, this is a small numbers issue. If there is something that isn't called out as one of the top causes in a particular sample of 2 years, it doesn't mean it's not also an extremely important driver of maternal mortality, especially on a national level, and also needs to be addressed. Similarly, there's the mention of the 2023 report, there are recommendations in that report that aren't in this one, and that doesn't mean those recommendations are null and void or that they've all been completed. You know, we wish for a world where all the recommendations in the 2023 report would have been completed by now, but that's not the world that we're living in. All of those recommendations still stand, and everything highlighted in our reports overall really matters to focus on. But I do want to particularly highlight how accidental overdose stands out in this 2-year period. So the timing of the deaths, most pregnancy-related deaths occurred within 43 days to 1 year postpartum, followed by deaths within 42 days of pregnancy. So we've really got an emphasis on the postpartum period here. And these findings really underscore the importance of care, support, and health insurance coverage through at least a year postpartum. And actually, when you look at these numbers specifically for the overdose deaths, that proportion in the later postpartum period is even higher. So again, a word about the fact that we're looking at fairly small numbers here. You'll notice that in this 2-year period, there's a relatively small number who died during pregnancy, but that doesn't mean that that period isn't extremely important. I'm focusing more on the fact that we have many of the deaths that took place postpartum really emphasizes the importance of that period, but it doesn't mean that care and support in pregnancy and birth are not also incredibly critical to this work and saving lives. So the panel identified contributing factors that led to each of the preventable pregnancy-related deaths, and these categories of factors are defined by CDC. These are the kinds of events or circumstances that, if different, the panel believes might have prevented the pregnancy-related death. So this graph on the left represents the top 12 categories of contributing factors. And I'm going to highlight the top 3, which were a lack of continuity of care and or care coordination, a lack of access to care or financial resources, and clinical skill or quality of care. These really played a role in the vast majority of cases, but you'll see there's many other categories of contributing factors here as well. And for each identified contributing factor, the panel made recommendations that could prevent future similar deaths. And I'll be going into the recommendations in the next part of the presentation. But before I move on to recommendations, I really want to highlight that the panel was having a strong focus on racism, discrimination, and bias, identifying and calling these out. And the panel found some type of discrimination, bias, interpersonal racism, or structural racism played a role in over 3/4 of the preventable pregnancy-related deaths from 2021 to 2022. And this does also include things like bias against people who are experiencing substance use disorder. But these findings particularly emphasize the need to center Black, Indigenous, and other communities of color as leaders in the successful implementation of many of the recommendations shared in this presentation and in the report. So now let's move forward and talk about the recommendations in the report. So the recommendations in this report, I want to first talk about how they're organized, just so it kind of makes it clear where and how to find things. There's 3 overarching priority recommendations, and all of the sub-recommendations are organized under those 3. And I'm going to go into what those 3 are in a moment. I mentioned earlier that we wanted to really make the legislative focus clear in this report. So we have 2 sections. There's first a section with 12 recommendations for the legislature. And I put the page numbers up on here as well, because again, it's really easy to miss one or the other of these sections. Those 12 recommendations for the legislature are actually really detailed. We wanted the overall number of them to be low, but we also wanted to give the legislature a lot of specifics and details. And then there's a second section that includes 75 recommendations for all the other audiences of the report. And this includes, but isn't limited to, health systems and facilities, healthcare and support providers, state and local agencies and departments, academic institutions, organizations, communities, coalitions, perinatal collaboratives, and many other types of groups and individuals. Okay, so those 3 priority recommendations that everything fits under in the recommendations section are: one is about improving healthcare quality and access, one is about strengthening community support services, and one is about providing equitable, culturally responsive care. So I'm going to delve into each of these three. So that first one, improving healthcare quality and access. This is specifically a recommendation to ensure that Washingtonians have access to high quality healthcare, including mental health care and substance use disorder treatment, as well as preventive care throughout pregnancy, birth, and postpartum. And to do this by things like strengthening and funding care coordination, improving communication and protocols, and also ensuring providers actually have the skills and training and professional support they need to provide high quality care. So I'm going to show you a couple examples of the recommendations that fall under this category. I'm not going to show you all 80-something recommendations in the report. That would not be processable. But in each of the three sections, I've tried to pull out a couple examples that I think might be of interest to folks in this group. So a couple examples in this first healthcare quality and access section. The first two are some legislative ones. So one is a recommendation that the legislature and also the Healthcare Authority and Office of Insurance Commissioner should require insurers to establish and increase reimbursement and eliminate reimbursement disparities for essential healthcare services and high quality care for pregnant and postpartum people. This includes specialized care for patients with mental health conditions or substance use disorder in pregnancy, particularly opioid use disorder. There's another recommendation for the legislature to protect and increase funding and access for family-friendly, judgment-free substance use disorder and opioid use disorder treatment and support for pregnant and postpartum patients, including in rural areas. There's a recommendation for DCYF to help healthcare systems and providers strengthen support for pregnant and postpartum people experiencing substance use disorder who may not otherwise seek care if they fear intervention by Child Protective Services or CPS. A couple other examples in this section. There's one for state and local health departments, health systems, healthcare providers, and relevant community organizations to raise awareness about urgent maternal warning signs, perinatal mood and anxiety disorders, and substance use disorder or opioid use disorder in pregnancy through public health messaging strategies and patient education. There's a recommendation for healthcare systems to implement a comprehensive training framework to ensure that providers use consistent screening tools to assess trauma history and mental health, embrace shared decision-making, and also prioritize listening to and validating pregnant, birthing, and postpartum patient experiences. And then finally, a recommendation for state and local agencies, including HCA, DOH, the Department of Commerce, local health departments, health systems, and community organizations to follow strategies for medical outreach and workforce development to increase access to prenatal, postpartum, and primary care for unhoused people. Okay, so the second priority recommendation area, this is the one about strengthening community support services, and specifically to invest in, develop, and expand comprehensive community support services that address essential needs in pregnancy and postpartum. Things like stronger home visiting programs, social work services, doula support, and wraparound support for mental health and substance use disorder. So a couple examples of the recommendations in this category that I want to pull out. There's a couple legislative ones here. One for the legislature to prioritize both protecting existing and funding new programs to meet people's basic needs in pregnancy and postpartum. Things like access to transportation, housing, income, and childcare is universally available. There's also a recommendation for the legislature to work with state agencies to prevent and reduce the impact of trauma. Mitigating childhood trauma helps prevent future maternal health complications and reduces the risk of developing substance use disorder or opioid use disorder. Supporting birth parents who have relinquished an infant either voluntarily or through child welfare systems helps stabilize their behavioral health, which can reduce maternal mortality. Like all of the legislative recommendations in this report, this one has many detailed examples under it, but I pulled out one of these to highlight for you, which was to invest in local social support systems that provide trauma-informed care for children and young adults impacted by child abuse and neglect. Couple other recommendations in this category. as examples. One was for DCYF to expand partnerships and provide funding for local social support systems that offer trauma-informed care and support for children and young adults who are or who have been part of the foster care systems or experienced involvement with child protective services. There's a recommendation for funders and state and local agencies to increase funding and capacity for community-based organizations to support people during pregnancy and postpartum. Things like culturally relevant parenting classes, community-led support groups, family reconciliation services, and trauma-informed therapy. And then there's a recommendation for DOH and local health departments to invest in building healthy and safe communities. This includes things like working towards systems level changes that address social, relational, and service gaps, and supporting communities in developing more robust early learning, education, childcare, parenting support, healthcare, and economic opportunities. So finally, the third priority recommendation area is about providing equitable, culturally responsive care. And this is about ensuring care and services throughout pregnancy, birth, and postpartum are culturally responsive, free from bias, grounded in trauma-informed practices, and actively address racial injustice. So a couple examples from this section. There's one for DOH and healthcare systems to fund tribal-led, indigenous-led, and community-led efforts to expand access to prenatal and birthing care in American Indian and Alaska Native communities, including in rural areas. And it gives some examples. There's also one, and I wanted to highlight this one because it directly calls out ACEs and PCEs. Healthcare facilities and providers, including primary care and support providers, should routinely screen for trauma history and tailor care to respond to the impact of trauma on mental health and well-being. This may include screening pregnant patients for both adverse and positive childhood experiences and offering enhanced wraparound care. There's a recommendation for clinical providers, including those working in emergency departments, to be trained to recognize stigma and bias and to provide trauma-informed care, including understanding historical and systemic factors that contribute to disparities in biased care provision, particularly in areas of pain management for BIPOC patients. And then a couple more examples. There's one for DCYF and partners to provide proactive community-based resources to help families stay safely together and to strengthen relationships between children and their fathers or other non-birth parents. This includes offering culturally relevant parenting support and addressing barriers such as incarceration, poverty, or CPS involvement, as well as expanding access to early voluntary services to support families during pregnancy and postpartum. There's a recommendation for healthcare facilities to implement systems that support and deliver patient-centered trauma-informed care for pregnant and postpartum people experiencing intimate partner violence, domestic violence, or gender-based violence. And then there's one recommendation that DOH should support systems change to prevent and address intimate partner violence, domestic violence, and gender-based violence by requiring trauma-informed care training and certification for providers and facilities. This also includes funding community programs that offer education, advocacy, counseling, and training for health systems to provide to support people experiencing violence. Okay, so I've given you some of the examples of recommendations in the report, and I just want to step back and acknowledge some of the current context and important issues, things that make the recommendations simultaneously sometimes more challenging to implement and also maybe more important to implement than ever. So some things like Medicaid cuts, which many of us have concerns about. I mentioned the disparity reflected, the larger proportion of maternal deaths that took place for people who are covered by Medicaid. This is one of the many types of intersectionalities in this report. Medicaid covers almost half of the births statewide. It covers 45% of them. When you look at rural areas, that number goes up to 70% of those births. And then simultaneously, there are rural maternity care shortages and concerns about those. There are challenges and fears all around the country about things like access to perinatal and reproductive care, and some of those can trickle down and impact Washington, even if they originate in other states. There's challenges around mental health care access. There are obviously all sorts of financial factors, state and local budget limitations, and just the current funding landscape overall. There's a lot of misinformation and disinformation about vaccines and some other topics as well. There are threats to immigrant, BIPOC, and LGBTQ plus communities, and also people perceived as parts of those communities. And finally, there's just a lot of uncertainty in these times about health, environment, and society in the future. We don't know what other changes are coming in the short or longer term. As one example, I think of before I started in this role, when the 2019 report came out in fall 2019, that was a couple months before the COVID pandemic hit. Nobody knew that that was coming. And that, of course, changed things in unexpected ways. So I want to acknowledge that, all of the uncertainty that can make these times very stressful. And it's also why the report includes recommendations that are both about protecting what already exists and about taking new steps, because both of those things matter. It's also why some of the recommendations require legislative support or funding, and some do not. So implementing recommendations. Implementing recommendations I think of as both centralized and decentralized in Washington. There are some things that are centralized, like if there's legislative change or some sort of statewide effort, DOH-led work across the state, and also the work of the Washington State Perinatal Collaborative, which if you're not familiar with, I recommend looking up and maybe getting involved in. They're kind of like an implementation hub of the MMRP, leading some efforts, but also trying to highlight the efforts of people around the state. And people around the state, that's where we get to decentralized implementation. This is all manner of local and regional efforts led by any organization, department, entity, coalition, or individual. This can be on the practice level to the regional level. It can be regional perinatal collaboratives. It can be any particular group in a specific region or beyond. It can, again, be as much as an individual. Any of that is implementation work. I mentioned that the report has success stories in it, and I just wanted to highlight one example because it is an example of a birthing center level story of implementation of a recommendation, a birthing center that was able to change a practice and distribute naloxone, to take home packets of 2 doses of naloxone based on an MMRP recommendation from a report. So just really want to acknowledge and honor all of the work that happens statewide towards these recommendations. But now I want to turn the conversation back to you and basically ask what's relevant to you in this group, in your community, in your workplace. Are there ways that the report's findings and recommendations can support your work and priorities? Are there recommendations that you're already working on, you want to start working on, somebody else is working on and you want to join? Who do you want to connect with, either in this group or elsewhere, to help support or strengthen work towards a recommendation or other efforts you might be interested in? So I want to open up for discussion about that, and also be open to any questions you might have. And thank you so much for patiently listening through a long presentation.
All right. So thank you so much, Debs, for your time today and for sharing all of this important information. And thank you to everyone who attended today to learn about the key findings, data, and recommendations from the MMRP report. I'm going to put a link in the chat. Please take a moment to complete the survey that's been put in the chat to share your thoughts on this presentation and any topic that you are interested in for a future ACES quarterly event. And if you would like to rewatch this presentation or share with others who may be interested, it was recorded, and a link to the recording will be shared in a follow-up email. So thank you, everyone. Thank you,
I just wanted to say thank you so much for having me and for this opportunity.
Thank you, Debs.
Thank you.
Have a nice rest of your day, everyone.